very good evening to you. I am Lisa Lord, and my special guest is indeed very special, as she is the lone female urologist on the island, Dr. Wanda Bellamy. Doctor, thank you so much for joining us on your program.
Thank you, Lisa. It's really good to be here. Thank you.
Thank you for accepting our invitation.
You're welcome.
Now, I want to start very basic by examining what urology is. Many times people hear urology, they automatically align it with just men's health issues. However, it's much broader than that. So break down what urology is.
Yes. So urology is a surgical specialty, different from a medical specialty, which is a nephrologist. Urologists deal with the urinary tract, surgical problems of the urinary tract in men and women, but also the reproductive or genital tract of men. In women, the gynecologist deals with the reproductive tract of the women. We deal with the reproductive tract of men. If you look at anatomy of the body, we deal with problems of the kidney, the ureters, which are the thin tubes that drain from the kidney to the bladder, all the problems of the bladder, the prostate in men, the urine passage or the pee passage, which traverses the penis, and then the genital tract would include the testicles, well, the scrotum, including the testicles, the tubes that drain the sperm from the testicles, again, the prostate, and, well, the sperm exits the body. So all those anatomical organs we manage if they have surgical problems.
And you work exclusively here at the Queen Elizabeth Hospital?
Yes,
and there's a structure for urology here at the QEH?
Yes. I'm currently only in the public sector, but in Barbados, generally, there's the private there's urology practiced in the private sector as well as in the public sector. In urology in the hospital, the QEH, it is under the heading of general surgery. We are not an independent department, but we are staffed by 2 consultants, 2 senior registrars, and all of us are qualified. We operate, we manage patients collectively and together, and then junior staff, which could include a senior house officer and an intern. So altogether, we manage all the public patients in Barbados who enter the doors of the QEH.
That's a mammoth undertaking.
It is a mammoth undertaking.
So let's break down urology even further now and looking at the conditions associated with it. Starting with kidney stones, which are very common. What are kidney stones?
So kidney stones are the formation of calcifications within the kidney, and not the kidney. If you look at the anatomy of the kidney, there is a solid compartment where toxins are filtered and urine is made, and then urine enters a more hollow section of the kidney called the collecting system. The stones tend to form in the collecting system due to many factors, usually metabolic factors, the difference of different types of salts in your body and how your body is handling those salts, and enough stasis of urine or enough stagnant urine stays there and gets stagnant enough that a calcification starts to form, a nidus. And from that, it builds and builds, and then you form a stone. Some of those stones obviously start small, and they can grow and fill the whole collecting system of the kidney. That's called a staghorn calculus. And they become very problematic because stones can cause pain, they could cause blood in the urine, they can cause infections, and certainly those large staghorn calculi can actually affect the function of the kidney over time and lead to non-functional kidneys, which of course, if you get non-function of your kidneys, you're tending towards dialysis. So kidney stones, yes, very common, and present a lot of problems. And when patients actually present with stones that drop into the urethra, it's an extremely painful situation. One of the worst pains known to man, actually.
And you've actually just described some of these signs and symptoms: pain, blood in the urine, and you mentioned something else just now.
Infections, and also dysfunction of the kidney over time.
And they're easily treated most of the time.
Well, once detected, that's another thing. Many patients with stones, especially if they're just sitting there in a small portion of the kidney and they are small, may be asymptomatic, meaning they do not have symptoms. And you may not know that you have stones until one comes and actually blocks the kidney. And that's a painful episode. Or you're developing infections and you have some kind of imaging, an ultrasound or an X-ray or CT scan done, and it's detected. But patients who actually have symptoms that are in keeping with kidney stones tend to get imaging. We identify the stone and then we decide on a course of management. Smaller stones sometimes will pass on their own. Even if they come and block the urethra, which is one of the ways a patient can present to the emergency department in that painful distress. We call it the acute stone episode. Those patients, depending on the size of the stone, how their symptoms are, and if they lack infection, we can treat that with medication and give them about 4 to 6 weeks to see if they'll pass it on their own. Bigger stones sometimes don't pass, and they will need a little help. Sometimes we have to place a temporizing tube, like a stent or a nephrostomy tube, and these tubes are just to bypass the stone. If they drop off of the kidney, to bypass that stone to help relieve pain or infection that's above the stone, and then come back and manage the stone definitively later on. The ways how we can manage stones that are in the kidney or in the urethra, this is surgically now, not medically, but we can do endoscopic surgery, which means there's no cutting, and enter the urine tract with small cameras and laser those stones. Now, although I say that, unfortunately at the QEH, we have not yet attained a laser to do that. That is available in the private sector, however, and we will obtain a laser in the near future so that we can offer these services to our patients. Another way, however, especially if stones are large, can be to remove them surgically, right? So as I like to tell my patients, a cut-in surgery. You actually get a cut, go down to the kidney or the urethra, remove the stone, all right? Laser would afford us the opportunity to have less open surgeries for our stones.
Another common infection or problem that you see are urinary tract infections.
Mm-hmm. Yes, we see a lot of that too coming through the emergency department. And urinary infections can be caused by many things, right? The patient himself or herself can have an immunity problem. So they're immunocompromised because of uncontrolled diabetes or, some other illness that is affecting their immunity. Another reason would be obstruction. For some reason, they don't empty their bladders properly, or the kidney is not able to drain adequately because of an anatomy problem of obstruction, or in men, a large prostate. A large prostate, well, this actually comes down, I'm bringing them from kidney stones now to bladder stones, which is kind of a different mechanism. But with a large prostate, a patient can develop bladder stones as well. The same kind of stasis of urine leading to formation of bladder stones. So a problem of the urine tract can cause you to develop stones and develop infections. You were asking about infections, really. Also foreign bodies. So, for example, I told you about placing a stent to temporize an obstructing stone. That becomes a foreign body. You weren't born with it. And one of the common foreign bodies that patients may have is a urinary catheter. For whatever reason it's placed. It might be placed for monitoring. It might be placed because they came in and they couldn't urinate. Whatever it is. When the catheter is in, it needs to be changed regularly, and we also need to get to the point of addressing the underlying problem quickly so that we can get rid of these foreign bodies, because they will predispose patients to infections.
And sometimes in talking to doctors, they say that they see a lot of UTIs for the simple reason that people get the urge to urinate and they don't go at the same time, they hold it.
Right. So good urinary hygiene or good urine habits are important as well. Your body is giving you a signal. You really should respond to it. Drink a lot of water too. That's another reason. Drink a lot of water and use the bathroom on time. And that would help to prevent, again, the stasis of urine, and keep things flowing. literally.
And again, most of the UTIs are easily treated.
Yeah, well, with antibiotics, but just remember also over time, if you're getting multiple antibiotics, those organisms that are growing start to develop, they get smart.
Yeah, they
They
get
start to
resistant.
develop resistance. And then you create some super bugs, as we like to call it, which are very challenging to treat. And we see those in hospital. We do see some challenging infections to treat in hospital because of various factors that cause patients to be having recurrent infections. So those factors need to be addressed as best they can to help the patient to stop developing urinary tract infections.
And at some point in time, man or woman will have a UTI. However, is there a number that you as a urologist would look for in the sense that this person has had 7 UTIs this year
Right.
that would raise a red flag?
So it so if you separate men and women, men may have obstructive reasons for forming a urinary tract infection. Their prostate might be the problem. But when you look at women with recurrent urinary tract infections, if they're having more than 3 in a year, right, then you get concerned. And these are urinary infections that have been proven. Not you just go to the doctor and they think you have a urinary tract infection. They gave you antibiotics. We actually sent the urine off for culture, and we proved that you have more than 3 in a year, right? Then you're looking at a situation where this patient has a problem. You have to find out what is the cause of the recurrent UTIs. Many times we don't find the cause. Yeah, and if there is a cause, obviously we treat it. But if there is no cause, then you have to recommend things like proper hygiene for women, proper hygiene after sex, even keeping the area clean, shaving the hair in the area, and then also using non-pharmacological and pharmacological preventative measures. Some of the non-pharmacological methods, really the one proven would be cranberry juice. Yeah. The thing about cranberry products, it's difficult. They're classified as foods. Like all herbal medication are classified as foods. So when you go and buy it over the counter, there are various formulations, various percentages of the cranberry, the extract that you're interested in from the cranberry juice in these different products. And to tell you specifically how much to take is difficult. Patients who take, then pharmacological ways of preventing recurrent urinary tract infections would include things like postcoital antibiotics, meaning a woman who has been diagnosed with recurrent UTIs, and especially if you think it's related to her having them after sex, if it's related to that, then you can prescribe for them an antibiotic, or give them a prescription rather, and a tube to do a culture. When she feels those symptoms coming on, she can go immediately to the lab, drop off her urine culture, and fill her prescription and start it. So that is one method. Another method would be to give a low-dose antibiotic course and try to just suppress the infections. And then there are some other preventative ways, but those patients, this is really females you're talking about with the recurrent UTIs. That's a whole topic on it by itself.
Yeah, and we want to give men some shine.
Definitely. So we ended up on the women.
Yeah, but I did take the point that cranberry juice is actually very good.
It has some benefits.
It has some benefits. All right. So you mentioned men and their prostate. So what is the prostate? What does it do?
So the prostate is a gland. If you could picture an apple, a red apple, that sits at the bottom of your bladder, right? And it is a gland that produces a fluid, this part of the seminal fluid. So when a man ejaculates after sex, or when he comes after sex, to use a common word, sperm is made in the testicles or the seeds, but that travels through the prostate and collects a whole set of fluid with it that's made by the prostate and then comes out as the ejaculate, which is what you see. So that fluid that the prostate makes supports the sperm and, helps nurture the sperm and keeps it healthy on its way out. It's very important.
What are some of these signs and symptoms men should look for that something might be wrong with their prostate?
So the prostate can affect men in a couple of ways. You can have an inflammatory or infectious problem with the prostate, which would be a prostatitis. It could be a benign enlargement of the prostate, and then, of course, prostate cancer. Okay, these are the three main things we would talk about. But the infectious complications of a prostate, like a prostatitis, really would present with irritable symptoms. So we call them lower urinary tract symptoms. And I would like to describe for you how it may go. So basically, a gentleman would go to the bathroom, or as he ages, the prostate increases in size. He goes to the bathroom and he's realizing over time he has to force, right? Or he has to wait. He has to wait for the urine to come out, and then he has to force a bit for it to come out. So he's standing there, he's forcing, and then it finally comes. The urine, I mean, it comes, and it goes the stream is very slow, so you get a weak stream. As it's flowing slowly, as if that wasn't bad enough, then it starts to stop and start, so there's an intermittent flow, because they kind of have to squeeze their abdomen to get this urine out, and it's just a problem. And then after that, when they finally finish, probably 2 minutes later, because they take a longer time to urinate, they zip up, leave the bathroom, and in 2 minutes they feel like they need to go again. So that's incomplete emptying. And that is kind of the progression of how men may start to see symptoms and how they may progress. Now, over time, that is because of an enlarged prostate. And the enlargement is happening, if you could picture a pipe or a drain of a pipe. As it starts to fill with debris, the debris blocks the flow of water. Yeah. Same thing with the prostate. As you age and it grows, it will start to obstruct the flow of urine out the bladder, and you get those symptoms. As that obstruction continues to progress, the bladder now starts to get bothered by this obstruction, and the bladder muscle itself will undergo some changes. And the symptoms of that include frequency. So now they're going very often during the day. So, every 2 hours, every 1 hour, they have to go and release some urine. Urgency. They cannot wait. The phone is ringing, or they're on a conversation with a friend, and they get that urge to urinate, off they go. No, not even hold on. They have to get to the bathroom, or they may wet themselves. And then the last one that we categorize in there is nocturia. So they're waking up more often at night now to urinate. So the frequency is in the night. And that can get very disruptive for a man's sleep. So if you're waking up, 4, 5, and 6 times a night, there is a problem.
Of course.
Yeah. And those are the main kind of 7 symptoms of an enlarged prostate. Now, we call those symptoms lower urinary tract symptoms. And the reason why I brought those in and told you about those, they're kind of non-specific. It does not mean only that your prostate is enlarged. It could be that you have an infection and you have the same set of symptoms. So we always have to ascertain really what is the cause.
And you do that with the specific tests, the prostate specific antigen tests, which most men prefer to do.
Well, the PSA, prostate specific antigen test, is more a test to screen for prostate cancer. So I was giving you potential symptoms of an enlarged prostate. If you want to talk about symptoms of prostate cancer,
please.
Yeah. Now, prostate cancer tends to occur on the outside of the gland. We spoke about the enlarged prostate occurring more on the inside of the gland. So on the outside of the gland, it means that you may not have symptoms for a long time, because you don't really get obstruction until later on, or it depends on where the cancer is growing. You may not get those urine problems. You may have blood in your urine, though. You may see it, or your doctor might detect it on urine tests. And that raises alarms in our head when you come with blood in your urine. One of the main things we like to rule out would be prostate cancer. But many men will be asymptomatic in the early stages of prostate cancer. And this is why it's very important to screen for prostate cancer. And by screening means detecting a disease early, before any symptom. So hopefully we could intervene early and cure. And this is what PSA is. It's a screening test. Men without symptoms You reach a certain age, you should start to screen for prostate cancer because many years can pass before you get a symptom of prostate cancer. And by that time, it's probably quite advanced. So screening is what I think you're asking me when you ask me about the PSA. And the PSA is a protein that the prostate makes. Yeah. So it's only made by the prostate. And therefore, it is made by normal prostate cells as well as cancerous prostate cells. Important to recognize that a PSA, therefore, is not specific to prostate cancer. It's a tool we use to detect prostate cancer. It's the trigger that we use to investigate further to see if you have a prostate cancer. But honestly, every prostate produces PSA. All right. So therefore, we have a level at which we will call normal. If your PSA is tested because you are presenting with symptoms or because you are screening and you have a PSA that's within the normal range, then you're thinking, unless you have some other clear-cut factor that you might have a cancer, the thinking is that you have a non-cancerous problem with your prostate, maybe a BPH, a benign prostatic enlargement. But if your PSA is elevated, and the more elevated it gets, you start to worry about prostate cancer. And this is why it's a screening tool, blood tests.
And more men prefer the PSA test than the physical exam. Tell me about this physical exam that many men tend to shy away from.
So before we had PSA to test, the main screening tool was to do a digital rectal exam, which is a finger examination of the prostate, and that is through the bottom, through the rectum. All right? But once PSA came on board, then that became the main screening tool. PSA is a blood draw, it's a blood test. Obviously, men prefer a PSA. Who wouldn't prefer a blood test over a finger examination of the prostate in the rectum? However, it is a normal part of a physical examination, especially if you've reached that age over 40 and you're screening for prostate cancer in particular. It's something that your urologist will offer to you or your GP will offer to you. But PSA is the main screening tool. And I don't want to say you don't have to get a DRE to screen for prostate cancer, but certainly a PSA is what is necessary. If we think that if you can have an elevated PSA, you may later need a DRE, a digital rectal examination. But I want to tell the public that you should not deter or feel that you should not go for prostate cancer screening just because you don't want a digital rectal exam. Get the blood test.
But is one better than the other?
The PSA is definitely more sensitive and specific than a digital rectal examination. Yeah. Uniquely, some cancers may be detected by DRE because the PSA is not elevated, but those would tend to be quite aggressive cancers. So aggressive that that it doesn't even make PSA. The cells are so abnormal they don't make PSA, so the PSA is very low. But when you do a DRE, you do feel a very abnormal prostate. But a PSA, I would say, and the guidelines are pointing towards that now actually, to say for screening, PSA is the #1 tool to use for screening.
Okay, so we have made it clear that PSA, in most instances, is better than the digital rectal exam in terms of the blood markers that you're looking for.
It's the most sensitive test. It's the primary screening tool. The digital rectal exam should not be used as the only screening tool. So I encourage men to do the PSA blood test. And later on, yes, you may need a digital rectal examination, but at least screen for prostate cancer with PSA.
And you keep hitting that golden number of if you're 40 and above, but you have younger patients as well presenting that might not necessarily have a family history either.
That is also a topic in urology, when to screen. If we screen every single man, you're going to detect too many, you're going to over screen, one, because there have been many men, especially younger men, who do not have prostate cancer. So why do it in them? The risk of prostate cancer under 40 is very low. And then above that, above 75 or above even 70 to 75, you have to beg the question, am I benefiting the patient by identifying a prostate cancer at that stage? Because many of those men may have prostate cancer, but a non-aggressive cancer that will never cause their mortality. They'll die from something else. They'll die from old age, cardiac disease, something else, but not necessarily prostate cancer. So there's the risk of overdiagnosing prostate cancer, believe it or not. And therefore, where our guidelines sit would be trying to identify that age where men should screen. The general age is between 45 and 50 for an average risk man and 70 average risk. But then there are a group of men who are being identified or who have been identified as high risk. And this includes men with an African descent. And that includes most of
Barbadians.
our public, right, exactly, mostly Barbadian men, sorry. Men with a family history, a strong family history of prostate cancer. And men with a known genetic abnormality that can increase their risk of prostate cancer. And what that means is that those men probably should be screened earlier. And the age for them is, the recommendation is to start screening at age 40.
So we're still at that age of 40.
Yeah.
We're not hitting that 25-year-old.
No. Screening below 40, there's no recommendation for that.
But are you seeing men under 40 with prostate cancer?
No, not in my setting, no. And from discussions with my colleagues, not really, no. It is a disease really of an older man, and 40 is the age basically that screening is recommended to be started.
In terms of persons presenting at the accident and emergency department with prostate issues, are you seeing men, because it is a slow-moving cancer, as you would have said before, sometimes you don't always have symptoms that could possibly present with a stage 3 or stage 4 prostate cancer?
Yes. So I do see a few patients, not the majority, but a few patients who can present with quite advanced prostate cancer and they never knew, or they didn't pay attention, maybe. I'm not sure exactly what the problem is, actually. I would love to know. But there are some men who may come to the emergency department with symptoms of a spinal cord compression. And what that means is they're paralyzed, their legs are weak or on the way to full paralysis due to compression of their spinal cord or the roots from their spinal cord because of lesions of prostate cancer that has spread to their backbones. That is quite advanced disease. And if you meet a gentleman, and I have met a few patients like this, who present with a PSA that is 5,000, a normal PSA is 0 to 4. So, and for the first time I'm meeting them, and the PSA is 5,000, they have a spinal cord compression. This paralysis could be permanent. And this is how I'm meeting them. And I ask, well, why? Why are you now coming? Yeah, I was working, life just continues, and they may be ignoring symptoms, or they just don't get to the doctor. So that is why screening is so important. And in our population where prostate cancer mortality in Barbados is in top 5 in the world, prostate cancer death in Barbados is within the top 5 number in the world. We have to encourage our men to screen early to see if we can get, a different outcome at the accident and emergency department, or men to present much earlier when they don't have symptoms, and we could try to cure. Because at that stage, there's no cure. There's trying to control and palliate. That's not where we want to meet you. We want to meet you long before that. Other symptoms I see guys come with would be, as I told you, blood in the urine, which may be a first presentation for some men. And when you do the workup and the test, the PSA and stuff, then you detect an elevated PSA. And that will prompt further testing with staging. We want to talk about that. Staging including a CT scan or an MRI scan to look to see if there's extension of that prostate cancer beyond the prostate itself or into the lymph nodes. Lymph nodes are, I like to tell my patients, waxen kernels of the prostate, around the prostate, right? That's where the prostate cancer will drain to. And then if it has spread to the bones or even other organs like the lung or liver, then that will be stage 4 disease. And at that stage, you're not really talking about curing. You can't talk about cures yet, unfortunately. You're talking about controlling the disease with chemotherapy or even hormonal therapy as the main basis of treatment.
Okay. Dr. Bellamy, still a lot more to discuss. Stay with us. You're watching One on One.
The Coastal Zone Management Unit wishes to advise the public that the reefs along the coast of Barbados are currently experiencing coral bleaching. Coral bleaching is a phenomenon where corals lose their natural coloration and appear bright white as a consequence of stress. In this bleached state, corals are vulnerable and may die if bleaching persists. Given the elevated water temperatures we have seen in recent weeks, it is believed that the coral bleaching is due to heat stress. It is hoped that once temperatures return to normal, the corals will recover. The Coastal Zone Management Unit will continue to monitor the situation and update as required. Thank you.
Welcome back as we continue our discussion with urologist Dr. Wanda Bellamy. Dr. Bellamy, we dealt a lot with the prostate in the first half. Let's look at men and infertility.
Okay.
A lot of times, a couple might be trying to have a baby. A lot of that blame is placed on the woman, but sometimes the blame should be placed on the man in the relationship.
And indeed, actually, the literature would tell you that 50% of infertility is male factor or due to the male aspect of the male side of the couple.
Half.
That's what the literature would say. So, in the evaluation of infertility, it should really be an evaluation of a couple. Female age and the female factors certainly have a lot to do with, and they're easy to assess. But in the male evaluation of infertility, his age does have a role, but men tend to still produce, they produce sperm every 3 days, new sperm, as opposed to women who produce the eggs before puberty, and that's it. Then you run out after that. So men do produce sperm, but then the quality, you have to look at the quality of the sperm they're producing, especially if the question of infertility is there. So one of the our main tests would be to do a semen analysis, looking at how the sperm look, how they move in that same seminal fluid we spoke about, looking at the DNA of the sperm to see if they're good quality for reproduction. Also hormones. So men need a good testosterone level or a good hormonal support, basically, to be fertile. So we would test their hormone levels as well to see if the problem is along that axis, what we call the endocrine axis, that's leading to a problem of infertility. So we assess them, their hormonal levels. We assess if the problem is at the testicular level. We also assess if the problem is not of the sperm, but of the path that the sperm has to take to exit the body. So all those are areas that we evaluate for infertility. One of the factors that could affect fertility that may be improved with surgery would be to correct a varicocele. And a varicocele is actually a set of dilated veins that surround the testicle and keep the testicle too warm, basically. That's why testicles hang outside the body, because they need to be cool. But if you have a large set of blood vessels, which we call a varicocele, surrounding the testicle, it may affect the function of the testicle. So if we detect that that's in a man who's being evaluated for infertility, their fertility potential may improve if we remove the varicoceles. That is one surgical way we can help with infertility. But if it is a hormonal problem leading to infertility, we can try to reverse that by giving the hormones that are lacking or correct that problem. If it's a problem of the testicle, which makes the sperm itself, it may be that we have to send them for a semen biopsy to remove sperm basically from the testicle and actually do in vitro fertilization with sperm. You understand? So there are different levels at which a man can be infertile and different ways we can manage it. If the testicle makes no sperm at all, well, the options become more limited. and adoption may be that man's only choice.
In terms of what you're saying here at the QEH, what's the most common reason for infertility?
To tell the honest truth, we don't actually see a lot of that in the public sector, infertility. Couples really going for infertility may actually start with their gynecologist, or they may start privately, or they may even go to the infertility clinic because we have one here. So it's not a common thing that I would see in the public clinic.
Let's look at something most men don't like to discuss. They also don't like going to the doctor because it is embarrassing. Erectile dysfunction, impotence.
Yes. So erectile dysfunction is a part of the whole sexual response cycle. So I mentioned that just to know that many things may contribute to a man not getting a proper erection, including his libido, which is his desire to have sex, the arousal, and then erectile dysfunction specifically describes the inability to get or keep an erection that allows satisfactory sexual intercourse. Men, generally, they may come to the doctor to talk about ED, but starting that conversation is usually or may be difficult for them. And oftentimes, or sometimes, you may see men come into the office, they kind of describe a couple of symptoms. They may not quite add up. Why did he come to the doctor? And the doctor is encouraged to ask the patient, well, how are the erections? And then the conversation flows. So it's something both the doctor and the patient sometimes are uncomfortable to talk about, but actually, once you get the ball rolling, the patient may describe their symptoms.
What are some of the reasons a man might suffer with ED?
ED is quite complex again. We tend to classify it into organic causes and psychogenic causes. The organic causes mean there's physically something wrong.
Right.
You need good blood vessels or good blood supply to the penis in order to have good erections, right? You need hormones. Your hormonal milieu must be good. And you also need the anatomy of the penis and the anatomy within the penis, where the blood fills the penis to cause a good erection. You need that to
Reaction too.
You need that to be functioning normally. So putting those together, if a patient has erectile dysfunction, you kind of have to evaluate all of the causes to see what you need to correct. And on the other side of organic would be psychogenic causes. Some men, for whatever reason, may have ED because of guilt, because of a lack of confidence, because they've suffered a traumatic event recently, like the death of a close family member, or even their wife or somebody close, and that can affect their performance and cause psychogenic ED. And then, of course, the two could be combined, which makes it more complex. So all those factors can relate to ED. Another cause of ED could be medications. So there are many men, we have a lot of chronic diseases in our community, hypertension, diabetes, even neurologic diseases. And certainly several hypertensive drugs, and this is in no way to discourage you from taking it, but some antihypertensives can cause erectile dysfunction, right? Or changes in your erection that you would notice. So I would advise that if that is the case, or if you suspect that your antihypertensive is causing the problem, consult with your doctor to see if the medications can be altered or even switched up, changed in any way to help with that situation, to see if it was the medication causing the problem. But don't stop it.
How do you go about making a diagnosis of erectile dysfunction? Because let's say, for instance, a man is under extreme stress. He cannot perform as he would like to. He had 3 times he went to have sex, and for some reason he just could not get an erection, or if he got an erection, he couldn't keep it.
Right.
Is there a gauge that you use in order to make that diagnosis?
Right. So it definitely starts with a proper history. As I said, there's so many factors that interplay. You have to sit. This is a long discussion with a patient. It cannot happen in 2 minutes. A long discussion about all the factors that could be related to their ED, including when the symptoms occur. You also want to ask them, for example, if they have good morning erections. A man having a good morning erection may indicate to you, but not able to perform,
Right.
may indicate to you that everything is functioning anatomically and hormonally, but there may be something psychogenic, or there may be a problem with the partner or that partner. So in questioning him, you get a sense of what could be the cause. If they've had, for example, like trauma to the area, or trauma to the pelvis, they were in a bad accident, and then they noticed erectile dysfunction after that, it could be that the nerves were damaged, or something was damaged relating to the penis itself. Patients with diabetes, and again, the medication history, cardiac history, and now that I mentioned cardiac history, sometimes erectile dysfunction, the man presents with erectile dysfunction, but actually that's the first sign that they have cardiovascular disease. So that will often leads to the evaluation of their heart. So a long history of all the potential risk factors is important to ascertain from the patient to get an idea of what could be the cause. After the history, obviously you would do a physical examination. You want to examine the general habitus of the patient. Obesity is a reason or a factor that will contribute to erectile dysfunction. Weight loss and exercise tends to improve erectile function, especially if it was one of the causative factors. Control of your diabetes and stuff like that. Also on the physical examination would be things like enlargement of the male breast, or a loss of, the size of the testicles may indicate that it's a hormonal cause. Something is going on with their hormones. The testosterone is not being produced in a normal way, and that could be affecting their erectile function. You would obviously examine the penis and the scrotum, the testicles, and just see if you detect anything. Prostate cancer can be, advanced prostate cancer can affect erectile function over time. Therefore, you would examine the prostate as well as a cause. So that's a physical examination. And then basically test, generally, again, the hormones, testosterone levels, hormones that are produced in the brain that help the testicles to secrete testosterone. You also would do their blood pressure, right? And their lipid levels, their cholesterol levels also. And if the patient gave you some indication that it could be a cardiac cause, heart cause, you need to investigate the cardiovascular system and even refer them to a cardiologist before treatment if necessary.
Well, let's look at treatment options for erectile dysfunction.
So if we spoke about non-pharmacological methods, we always like to start, and patients like to hear about that. You would be talking about weight loss, control of your chronic diseases, altering of medications that may contribute to the erectile dysfunction. In terms of medications or pharmacological treatments, the main ones would be the PDE5 inhibitors. So the common names would be Viagra, and that's probably the most common one that we hear about, Viagra and Cialis. These are tablets which are used to help patients with erectile dysfunction. These medications, funny enough, were first introduced for lung problems and then found to actually assist with erectile function. They are medications that need to be taken after we have clearly identified that your heart doesn't have a problem, because they can actually lead to cardiovascular problems. When we prescribe them, have to describe how the patient should take the medication. You don't pop the pill and get it up. That's not how it works. Basically, these pills need to be in your system and on board. So now sexual intercourse becomes more of a planned activity. So you need to take it at least 30 minutes to an hour, depending on which drug you're using, before sexual intercourse. You have to watch some of them. You have to watch what you eat before the sexual intercourse, because a very fatty diet may interfere with the efficacy of the drug. You still need the stimulation. You will not get an automatic erection. Still need the stimulation from your partner whether it's masturbation or the partner will be actively doing something to arouse the patient, that needs to be performed still. And then if the erection is good on medication, they can perform. Some patients may come to us and say that it didn't work. But before we call it a failure, you go back through all the steps of how you need to effectively take the medication, or how you need to take the medication, and what needs to be done before we call it a failure. And we'll give a couple tries before we call it a failure. If you fail on one of those medications, you can switch to another, because some men will do better on one particular medication. And you can try another medication. You can increase doses. And that is one of the main methods, because it's a tablet. The warning about the cardiovascular effects with the tablet is that the tablet basically increases the blood supply to the penis. It also, by dilating blood vessels. If you already take heart medication, especially nitrates, like you spray a little nitrate under your tongue for chest pain, then those medications are not for you, because it will cause such massive dilation or dilatation of your blood vessels. It can actually give you a heart attack. And that's why we also screen for cardiovascular disease when we do that, and know your medication history. In addition to, just very quickly, in addition to tablets, or the next step after tablets for erectile dysfunction includes things like injecting medications into the penis to actually induce an erection. And those become necessary, especially in patients who have nerve problems. There's something called the vacuum pump. Basically, it fits onto the penis, and it sucks blood basically into the penis to cause an erection. You wear a ring to keep the penis erect, and then you perform. Of course, you have to take off the ring soon after, right after. Beyond that, you're talking about surgical options. And surgical options obviously are permanent, to replace the inside of the penis with either a flexible metal device. These are penile prostheses, or even a blow-up device, which is an inflatable device. And, those options are available, honestly, for any patient with erectile dysfunction. However, they are permanent. You have to realize there's no reversal if you go to that stage. They're not yet available. No one here is doing the penile prostheses, but certainly in the world, that's an option.
You mentioned Viagra and Cialis, two drugs that we know are very popular for erectile dysfunction. However, you have persons using sexual enhancers that do not need them, simply because they want to last an hour, maybe 2 hours. Tell us about the dangers in doing those things.
Right. Well, taking anything that's not necessary is just not a good thing. I guess it depends on what the couple wants. If they want to last longer, they want a longer sexual encounter, I suppose that is their choice. However, remember, the side effects will be similar to they still have components of the drug. So side effects include the same dilation of blood vessels in your body. It can cause facial flushing. It can cause bad headaches. It could cause nasal congestion. And, well, God forbid you had an underlying cardiac illness that you didn't know about, then you expose yourself to the risk of something like that. So, I would say keep away from things that are not necessary if you don't need it.
In terms of what you're seeing in practice here at the QEH, what bothers you?
Just to highlight some concerns that you want to warn patients of things not to do. For example, placing foreign objects into their urine passage for whatever reason would not be wise. First, it could damage the passage. It could obstruct the flow of urine, can cause infections.
What kind of foreign objects?
For an example, and not here, but I've actually encountered a patient who had a hairpin placed up his pee passage. And then, of course, they couldn't get it out. So we had to take it out in surgery. But stuff like that, for whatever reason, he didn't give a reason, they wouldn't give a reason, but those foreign bodies would be dangerous to their urine passage and also to the bladder.
Do you get patients placing the beads in that passage as well?
I've never had a patient with the beads in the passage, but we do see the patients who have the boogaloos placed under the foreskin. Most of my patients that I've seen with that, they don't have a problem, but they can lead to infection based on how they're put in and the conditions under which they were put in, because they're not normally placed in a theater setting. So the risk of infection is there. And I've had a couple of patients who've asked that we remove them as well. So just think twice before you decide to alter your penis in that way. Another concern would be patients who have a catheter and who may be tempted to remove it themselves, right? So pulling a catheter out of your bladder will damage you. And usually you will end up in here with blood coming from your bladder or your urine passage, because there is a balloon at the end of that catheter that's keeping it in the bladder, and it's quite dangerous for you to pull it out. Rather seek some medical advice, see if it can be removed or when it can be removed. Another dangerous thing is to cut the catheter, because that means it will go back into the bladder and it has to be retrieved via surgery. So those would be practices that I would tend to think you should avoid. So other concerns would be more clinical or medical things. So presentations of infected scrotal skin. That's called a Fournier's gangrene. That patients may present with a outright gangrenous scrotal skin. It's black. Or it may start more insidious and just be red and painful and swollen. But at that time, then we have to do surgery and remove all that infective tissue. And that is pretty much a urological emergency. They come to theater and they come to the hospital and they're actually very sick and they need that dead tissue removed and antibiotic treatments. Another set of emergency things that we see coming through the department would be testicular torsion. This is now for the younger guys, more so, especially kids, and then some of the younger adolescents. They can have an acute, painful testicular episode, which is due to a twisting of the testicle on its blood supply, or a twisting, of the testicle on its blood supply. That is a hot urological emergency. You have a time window of 6 hours. You need to get here, get evaluated, get to surgery, and get that testicle untwisted. Otherwise, after that, it would die. And as I like to say, time equal testicle. You need to work with the time and get here. So be aware of your boy children and aware of men complaining of an acute testicular pain. It might be testicular torsion, and time is a factor.
I know that you mentioned boys. We hear about children sometimes suffering with tight foreskins.
Yeah. So boys are usually born with what we call a phimosis. The foreskin is tight. It might just be a pinhole opening to allow the urine to pass. And over time, it will open up. But some boys have a lot of difficulty with that, especially if the parents were not either advised or were not successful in stretching that foreskin as the child was growing in the infancy. So it's actually important to advise parents to stretch the foreskin daily with baths. I did it for my sons. Daily with the bath, stretch the foreskin gently, not to cause discomfort, but gently enough that over time the skin stretches and they don't end up with a tight foreskin at age 5 and 6. Because at that stage, the skin is much tougher. That's one. And two, you can't get a 5-year-old, you can't get a foreskin back on a 5-year-old. They'll be screaming. At that time, then, if they need, we might have to offer a circumcision to help relieve the problem, because as they can't clean the head of the penis properly, infections can occur, pain, and it really becomes a problem for the youngsters. So we offer a circumcision if they couldn't successfully pull it back.
There is something that I want to get in, and in this case, being quick is a good thing. Penile fractures. How common are they?
Penile fractures. They are not overly common, but I've seen about 3 for this year, 3 or 4. The risk factor is really men. Well, how it occurs is that the man is thrusting during sexual intercourse, the penis slips out, and then it hits against the blunt buttock or thigh. And with a very erect penis, that actually ruptures the lining inside, basically. We call it a fracture. So they immediately lose the erection, it swells, and they come to hospital. They might even hear a crack, the cracking sound of it. Don't worry. It's something
really
we can
painful.
fix.
Yeah.
It is something we can fix. So when they come, they're evaluated. We take them to surgery. We deglove the penis. We look at the area. We repair it with stitches, and usually the result is good. The only dangerous part sometimes is if they actually injure the pee passage as well, the urethra. That would also need to be repaired as well. So it is something not that common, but it can occur. And of course, it's embarrassing when they come sometimes because it was during sexual intercourse, but it can be repaired.
Okay. Dr. Bellamy, even quicker now, why choose urology?
Well, I always like surgery. That's the important part. And urology is a field which is separate and apart from general surgery. So we have our own, as we highlighted at the beginning, our specific organs that we deal with. I like the pathology of it. I like the surgery of it. I also like the medical aspect of it, because you realize with erectile dysfunction, there is incorporation of many medical aspects. And I like dealing with, although we deal with female patients, I do like dealing with my male patients.
Your day-to-day activity must be very exciting, for lack of a better term right now.
Yeah.
Well, thank you for sitting and chatting with us this evening. I really appreciate it.
You are welcome.
Thank you very much. That was Dr. Wanda Bellamy, the island's lone female urologist. I'm Lisa Lord. You're watching 101. Do have yourself a wonderful evening.